filled with me.
I guarantee you'll never have a problem.
Yeah, before we used to have
I thank him every time I have to park in Boston because he made me.
Good morning. I'm Teresa Famine. I'm the chair of CEPAC, and I would like to welcome all of you today to the New England CEPAC meeting of abuse deterrent formulations of opioids. As always, ICER chooses topics that are challenging and timely, and this one in particular, I think, fills both of those criteria. To start, I just want to mention that at the beginning of every meeting, we want to ensure that all speakers disclose any financial relationships with the health industry. Every member of our CEPAC who are here today has met the ICER conflict of interest policy, and I just want to ask if there are any updates from any of the members. No? Okay, great. And then any other speakers, including our policy roundtable participants and individuals making public comments, should be sure that they announce any financial relationships before they speak. And we'll present this information on slides as well. I'd like to introduce or go around and have the members introduce themselves. And I just want to say I am a rheumatologist from the University of Vermont Health Network at Central Vermont Medical Center in Berlin, Vermont. And I've been on CEPAC since its beginning, and it continues to just keep getting better. Jean, do you want to start?
Are these in a minute? So I'm Jean Ryer. I'm the director of the New Hampshire Citizens Health Initiative at the University of New Hampshire Institute for Health Policy and Practice.
Good morning, Kim Lenz, Clinical Pharmacy Manager for the Massachusetts Medicaid Program, an Assistant Professor in Family Medicine and Community Health at the University of Massachusetts Medical School.
I'm Keith Stahl, practicing internist and Executive Medical Director for Primary Care and Population Health at Catholic Medical Center in Manchester, New Hampshire.
Good morning. I'm Stacy Brown, Director of the Community-Based Education Office at the University of Connecticut School of Medicine.
I'm Ed Westrick. I'm an internist, primary care physician in a community health center in Rhode Island, former pharmacoeconomist.
Hi, I'm Stephanie Nichols. I'm an associate professor at Hudson School of Pharmacy and a psychiatric pharmacist and substance use disorder pharmacist.
I'm Greg Kerfman, editor-in-chief, Harvard Health Publications at Harvard Medical School.
Austin Fracht. I'm a health economist, and I'm the director of the Partnered Evidence-Based Policy Resource Center at VA Boston Healthcare System.
I'm Dor Ann Mills, and I'm a public health physician and administrator at University of New England.
Good morning. I'm Jason Wasfy. I'm a practicing cardiologist, director of cardiology outcomes research at the Mass General Hospital, and I'm assistant professor at Harvard Medical School in Boston.
And I'm Claudia Gruss. I'm a gastroenterologist and internist with the Western Connecticut Health Network, as well as being a clinical educator for their fellowship program. I'm also chair of the Quality of Care Committee of the Connecticut State Medical Society.
I'm Brian O'Sullivan, pediatric pulmonologist at Dartmouth-Hitchcock Medical Center, and medical director of the Clinical Research Unit in Manchester, and professor of pediatrics at the Geisel School of Medicine at Dartmouth.
Morning. My name is Nathaniel Katz. I'm a pain management physician and researcher, and I've spent a good bit of the last 25 years trying to figure out how to do better research on both the benefits and the risks of opioid therapy, and I'm here to support the panel should any questions come up that I can help you with.
Good morning. My name is Bernie Good. I'm a internist from Pittsburgh. I'm a professor of medicine and pharmacy at the University of Pittsburgh. And I chair the medical advisory panel for pharmacy benefits management for the Department of Veterans Affairs.
Good morning. I'm Shanna Smith, Director of State Advocacy and Alliance Development with U.S. Pain Foundation, but I am also a chronic pain patient and will be providing the patient perspective during this afternoon's policy roundtable discussion.
Thank you. I just want to make clear that Dr. Katz, Dr. Good, and Shana are not members of our panel. They're here as clinical experts and patient experience. Next, I'd like to introduce Dr. Steve Pearson, who's the head of ICER.
Good morning, everybody. Thanks for being here. And obviously, we have a topic before us that the whole country is wrestling with. So it's a pleasure to have had the engagement of the clinical experts, the patients, manufacturers, and other stakeholders as we tried to put this all together. You've now heard from the members of the New England Comparative Effectiveness Public Advisory Council. And just to restate, in a way, what you heard, they are an independent appraisal committee comprised of experts in methodology, in clinical practice, in applications of evidence to healthcare and health policy. And they meet in public deliberation to really, again, explore the evidence, to question, to hear from stakeholders, and to render some judgments on the strength of evidence on both effectiveness and value. ICER serves as the kind of background superstructure, if you will, and as the academic resource for the CEPAC. So I wanted to briefly lead you through some aspects of ICER. As an independent nonprofit foundation, we receive funding from a variety of sources. This is the current snapshot for 2017. The money that comes in to support the reports that we do are represented in that red block of 78% of our overall revenue that comes from nonprofit foundations. The primary foundations there are the Laura and John Arnold Foundation, the California Healthcare Foundation, and the Blue Shield of California Foundation. We have a separate policy summit program for which we take contributions from both manufacturers in the pharmaceutical industry and from health plans and pharmacy benefit managers that is used for that program that represents about 20% of our revenue, and about 3% comes from government contracts and grants. So why we're here today, again, is really not too much of a mystery to anybody, but we are, as a country, facing one of our greatest public health and social crises in many generations. And it extends across the country. New England has been in some ways hit particularly hard. And it wasn't difficult for me to just scan some of the public media and to find in the New Hampshire Union Leader a report from earlier this year that said that the number of people in New Hampshire to have died in the previous year from drug overdoses is expected to have climbed to 478, which was 22 more than in 2015. And 70% of those were the result of overdoses with fentanyl or fentanyl combined with another opiate. New Hampshire, Vermont, Rhode Island, Maine, Connecticut, Massachusetts, every state in the country and in New England is wrestling with this problem at a public health crisis level. It cannot be denied that we are also confronted with important patient need for pain control. Pain is a significant medical problem, pointed out by a comment we received from the Institute for Patient Access. And it does have potentially devastating costs for patients, particularly for those with chronic pain. Opioids can be a valuable medicine for pain patients, but they also present certain risks. Abuse-deterrent formulation opioids are an emerging technology that can help protect pain patients' access to necessary medications while helping to reduce costs associated with the current opioid addiction crisis. So part of the balance or the tension that we'll all be addressing today is the public health crisis and the patient need for adequate pain control. And we're also here because this tension in some ways has highlighted important questions about the effectiveness, the value, and the affordability of different treatment options for pain, and for today's focus on abuse-deterrent formulation opioids. Here's a quote: "These are very expensive formulations, and we don't have any evidence of direct patient effects." Again, you can cherry-pick quotes in the public media from a lot of different sources. I picked one from Ed Mishna, who's a board member of the American Pain Society and a pain specialist at Brigham and Women's Hospital in Boston. Another source of concern is raised by those who are looking at health system budgets. And a quote from an article in Health Affairs says that in fiscal 2016, the VA's opioid costs, and I think one of the co-authors on that paper is with us today, Dr. Good, the opioids costs were nearly $100 million, and of this only 1.9% were for an abuse deterrent product. They estimated that switching all patients to ADF opioids would result in approximately a $1 billion yearly cost for opioids, and it could represent as much as 20% of the entire VA pharmacy budget. So, highlight again, the public health crisis, very real. People dying every day in this country because of the opioid epidemic. We've got patient need for adequate pain control, and we've got real questions about affordability and about effectiveness and value of different treatment options. So we are here to deliberate on the evidence, the best that we could do at ICER to pull that evidence together to help inform decision-making. We'll talk about decision-making at the bedside, we'll talk about decision-making within health systems, but also decision-making at the broader societal level about how we approach opioid treatment, what is the role of ADF opioids, and how do we think about legislative and other kinds of approaches to structuring the care to try to manage the tensions that we've talked about. We're here to get input from all stakeholders and to discuss the policy options as we move through a discussion of the evidence. Later we'll have a policy roundtable where we'll have payers, we'll have clinical experts, patients, and manufacturers represented to discuss the policy options going forward. So the report that was the background, if you will, for this meeting today, I just want to briefly describe how it was created. First, ICER starts with what we call a scoping phase, where we start very broadly, talking, seeking guidance from patient groups, from clinical experts, from the manufacturers in the area, and all other stakeholders to try to understand what are the key questions, what are the key issues and perspectives that need to be considered. We then perform an internal ICER staff review, looking at the evidence, and we develop cost-effectiveness modeling to try to grapple with that difficult question of how different costs in the health system balance each other with the outcomes that we can expect over time. We go through different phases of public comment and revision of those reports, and we also have expert report reviewers. For this report, they were the four individuals listed there. And then I also want to just talk briefly about how the evidence report is conceptually structured to talk about effectiveness and value. What do we mean and how do we think about those? Well, in ICER's view, we try to maintain a common goal with all stakeholders that we believe we really share, which is to try to seek a way to achieve sustainable access to high-value care for all patients. To do that, we think there are two considerations that stakeholders want to consider. One is the what we call long-term value for money of different treatment options, and the other is the short-term affordability of different treatment options or care options. Now, within long-term value for money, there are these subdomains making up that broader term. One is a focus on comparative clinical effectiveness, full stop. What can we say from the evidence we've got about the clinical effectiveness of option A versus option B, et cetera? Then the incremental cost effectiveness takes those understandings about the comparative clinical effectiveness and again tries to model those forward in time to try to understand how those outcomes differ and how the costs associated with those outcomes stack up. And it's looking across all aspects of the health system, not just drug costs, but hospital costs, doctors' visits, et cetera. We like to make sure that we remain open and sensitive to the fact that there are often other benefits or disadvantages of different treatment options that may not fit cleanly within the usual domains of comparative clinical effectiveness or cost effectiveness. These are things such as public health effects. They can be different broader effects on families or communities. And contextual considerations often really focus in on the condition itself. Is it a very, very severe condition? Have there been treatments available before? What are some of the broader social values associated with treatment options for the particular condition? So the report tries to make sure that we keep our eye on all these different factors and structures so that the report can hopefully support a discussion about long-term value for money that will consider all these different domains. And for short-term affordability, for many decision makers, it's important to also think about not only the long-term value, but whether there are potential tensions around short-term affordability. And I know we'll be talking about that today. And for that, the most useful quantitative input is a consideration of the potential budget impact. So that's the way that the structure of value, if you will, and affordability is structured in our reports. So at this point, let me let Celia Siegel, our program director for the New England CEPAC, just lead you all through the agenda and some other logistics, and then I'll introduce the presenters of the evidence review.
Good morning. Thank you all for coming up to Concord, New Hampshire. I'm just going to walk you through the agenda for the day, as well as just run through some logistics. We've convened at 10 a.m. After this brief introduction, we're going to move into the presentation of the evidence. We're going to have Dr. Rainer Bankin and Dr. Rick Chapman up here presenting our findings from our report. We will then invite our manufacturer public commenters to this front table here to deliver their public comment, followed by questions from our panel. Afterwards, we will invite our public commenters to deliver public comment from that microphone, standing microphone over there on the right, looking out at the room. At 12:15, we'll break for lunch. We will have lunch for everyone here. Lunch will be served out in the hallway for members of the public, and we'll also have a room for our panel members to eat lunch where we met this morning. We will reconvene at 1 p.m. for our deliberation and votes. We will, at that time, invite our experts to the front of the room to answer any questions that come up during that deliberation. We have almost a full 2 hours for our policy roundtable, which I know many people are participating on. Again, we'll invite everyone up to this front panel to participate in that before voting on the final question, question 4, which everyone should have in your packets. We'll end the day with reflections from our panel, and we will adjourn by 4 p.m. A few notes: we'll have coffee and water all day in the back, so feel free to grab coffee and water if you need it. The bathrooms are out here to the left down the hallway, so if you know where the bathrooms are. And we'll also have timekeepers for public comments. So we'll have a laptop with a countdown watch just kind of stationed up here in the corner so that people know how much time you have left. Feel free to come grab me if you have any questions throughout the day, and thanks for coming.
Yeah, I think I also wanted to note what a pleasure it is to be back in New Hampshire. ICER kind of tends to do a home and away, where we do a meeting in Boston, and then we make sure to kind of keep our roots, which are we're in a collaboration among all 6 New England states, alive by making sure that we bring these meetings and these discussions to every New England state over time. And it's a real pleasure. This is at least our second, it may even be our 3rd meeting in New Hampshire. So just want to briefly introduce the presenters of the evidence review. Dr. Rainer Bankin is a senior research fellow in the WHO Collaborating Center for Knowledge Translation and HTA in Health Equity at the University of Ottawa, and has worked with ICER for some time now. He's an expert in health technology assessment. Following Dr. Bankin, we'll have the presentation of the economic information from Dr. Rick Chapman, who's the Director of Health Economics at ICER. So, Dr. Bankin.
So we're going to talk about ADFs, a very complex theme. I'm going to run through the presentation. Anyway, we have lots of time afterwards to answer specific questions if there are any. I did some work for companies over the last year. This is not related to ADFs. None of these companies produce ADFs, and it's not related to any of the symptoms or diseases where ADFs are needed. And I worked with a great team at ICER to do this report. It's important to understand that ADFs, its abuse deterrent formulations, are designed to deter specific routes of abuse. So an ADF can be abuse deterrent for intranasal or injection, but it has to be specific for that, and it's approved for that. And there are some cases, for example, where Opana, which is not an ADF, does not have an ADF label, where you introduced intranasal abuse and it went to IV abuse. So it's important to know ADF is for a specific route of abuse. It uses physical and chemical barriers, agonist-antagonist combinations, and that's what currently used. It can use also aversive agents and prodrugs, but there are no approved ADFs on the market currently with these later technologies. The ADFs we are talking about are ADFs as approved by the FDA. These are opioids with an abuse deterrent label. You do have opioids on the markets that do have properties of abuse deterrence. I just mentioned Opana. But these opioids are not recognized as ADFs, and we did not include them in the review. So these are the 10 opioids that currently do have abuse deterrent label from the ADF. 6 of them are available on the market. 4 are not available on the market. 9 out of the 10 are for extended release opioids. Why extended release? Because you have a drug dosage for 24 hours in one pill. So if you're able, if an abuser can get the drug out of the pill and inject it, for example, he has a much higher effect. That's called dose dumping. That's why ADFs, it's one of the reasons why ADFs have been developed first for extended release. The one ADF immediate release is Roxybond, which has been approved recently. It's not yet on the market. So you've got, this is why we are here today. It's the death rates associated with opioid abuse. So between beginning of 2000 up to 2010, the death rate increased 4 times, and this was parallel to the availability of opioids, to the prescription of opioids. As you see, it has been leveled off over recent years, but the overall death rate has continued to increase due to illicit opioids, fentanyl, heroin, and others. In New England, the rise in death rates has been one of the highest all over the U.S. Between 2010 and 2015 in New Hampshire, the deaths have tripled. For every death, there are 10 admissions for treatment of opioid abuse, 32 emergency department visits, and around 130 people who abuse. Each year, there are around 220 million prescriptions of opioids. 90% of these prescriptions are for immediate release, 10% are for extended release, and of these 10%, about 1/3 of the prescriptions are for ADFs. On this slide, you see the market share of the different ADFs. So you see it's basically OxyContin that does have a huge part of the market share, which actually is decreasing, has been decreasing over the last years. Testing your knowledge. These are some slides from the FDA for a presentation for pharmacists. And there are 2 questions I'm going to present, and I'd like you to have a look at, which are important to understand the context, understand the evidence. So the first, select the way that abuse-deterrent opioids can be abused. I'm not talking about opioids. Which are the ways in which ADFs can be abused? Swallowed, crushed and swallowed, crushed and snorted, crushed and smoked, dissolved, injected, or they cannot be manipulated. More than one answer is possible. These are the answers. ADFs are abuse deterrent. They are not abuse proof. The next question, which of the following is the most common form of abuse? I'm talking about opioid abuse, not ADFs, just general opioid abuse. So which do you think, which of the which is the most common route of abuse for opioids? Let you think about that. Swallowing. Swallowing pills whole. So there you see the limits of what an ADF can do. We have seen the opioid epidemic of deaths. There are a certain number of policy actions on these. ADFs is not the only answer. It can be one of the answers. So, for example, state policies, there are 5 states requiring insurance coverage to cover ADFs without any additional barriers to access, and Massachusetts was one of the first in 2014. Massachusetts uses a deliberative commission to decide which ADF should replace which opioid. It is not currently in place because of these different requirements, sort of which opioid should replace, the work that needs to be done to get the policies into place. Only in 2016, 20 states have introduced similar legislation. You have got the 2016 CDC guideline with 12 recommendations for prescribing opioids for chronic pain in the primary care settings. And they said, first of all, do we need to have an opioid? So there should be non-pharmacologic and non-opioid therapy should be prioritized. Coverage policies, among the coverage policies we looked at, OxyContin was the most likely to be covered. Xtancia was the least likely to be covered. Few of 1/4 of the plans that were reviewed, the information is in the report and the evidence summary. Insights gained from discussion with the patient and patient groups. Patients insist for a need for continued affordable patient access to opioid therapy for daily function. This is very important. Many patients have the impression that the different measures to diminish the use of prescription opioids have increased the barriers of access to opioids. This is one of the messages we are getting. And patients insist on the importance of having access to specialized multidisciplinary pain care. So opioids should be seen as part of an overall access to pain care and to specialized pain care. So how strong is the evidence that ADFs improve outcomes? Yeah.
Do you have any data on the percentages of the forms of abuse? Like is swallowing the overwhelming percentage of the forms?
Okay. It depends on the substance. So for oxycodone, and where do you get the data from? So the data we have on the routes of abuse is from admission for treatment. So you don't know about the abuse patients who are not admitted for treatment. This is one of the problems with abuse. We have very little knowledge about the natural history of abuse. How do patients progress from taking opioid or having a recreational use? How do they progress along the line? There are very few cohort studies available. So the data we're having is admission to treatment. So patients being admitted to treatment for oxycodone, I think it's about 2/3 taking it, swallowing pills whole, oral use. I think it's for morphine, it's predominantly IV. So it really depends on the substance.
Okay.
Can I just ask a follow-up question to that? Because I really appreciate these slides because I think this is a critically important part for us to understand how effective these medications are. It's critically important to understand the epidemiology of abuse. And so I guess it sounds like the gap of the literature in this sense is that we know when people are admitted to the hospital or evaluated in patient settings. But is it, I know this is a tough question, but do you think it's safe to assume that if we know the epidemiology of those who end up in emergency departments, the epidemiology of abuse, snorting versus pills versus whatever, that is it safe to assume that among the population of patients who are abusing these medications in the outpatient setting and are not evaluated, that there's more pills in that population, or is that not a fair assumption?
It's very, very difficult to answer that question. Maybe in the policy roundtable we can go back to that. I think maybe some of the specialists may have some answers to that. You've got the phenomenon of diversion also, being pilled, being prescribed for somebody else and being used by somebody else. So lots of this is very complicated. But overall, I think our understanding about the epidemiology of abuse has lots of challenges that is being reflected in the Natty, I see you want to answer that one, or just a question, or maybe... You want a quick answer? Yes, why not? Yeah.
The more advanced the patient is in their trajectory of abuse, the higher the proportion of them are manipulating as they ingest it. So you'll find more injection and more snorting when you go to substance abuse treatment centers, but if you look out in the general population where it's just your average casual abuser, then the percentage of those people who are injecting it or snorting is much lower.
Okay. So this is the clinical development of ADFs. There is extractability, temperability testing. Are we able to grind, for example, the pill? We are not going to talk about this in the presentation. The next step is pre-market studies of what is the potential of abuse. I'm going to describe this later. We are going to talk about that, as well about the observational studies on real-world evidence. We cast our evidence net very widely, really to get the full picture of what an ADF can do. Very few exclusion criteria. So populations, all persons using opioids for therapeutic and non-therapeutic purposes. In the scope, we included cancer pain, but we did not find any specific studies on ADFs and cancer pains. That's why we were unable to deal with this topic specifically. But the evidence net, we had it that wide. Interventions, as I mentioned, abuse deterrent opioid formulations with an ADF label. Please keep this always in mind. You've got quite a few reports who use the term ADF and include opioids that do not have an ADF label. Outcomes, patient level, population level, health system, society, no exclusion on this. The cutoff date for the evidence review was May 31st, 2017. Overall, we found 15 pre-market RCTs and 26 post-market observational studies. So these 15 randomized, crossed-over trials evaluating oral and intranasal abuse potential of ER ADFs. For Roxibond, which is the immediate release, there was no published studies, so we reported the intranasal abuse potential data in the FDA prescribing information. It is important to understand that these pre-market studies are being done among healthy, non-dependent recreational drug users. So people undergo an naloxone challenge before, they are not dependent. It's a very particular set of participants which are not representative of the overall population of people who abuse, but it's the best way to get people who are able to discriminate between the different drugs, between the control and the money-manipulated drugs. So this is how it has been set up. So there are different comparators in there, and the endpoints is a visual analog scale about drug liking and willingness to take the drug again. Did I like what I experienced? Would I like to have this drug again? So they mark these results on a score. So for the abuse potential relative to non-ADF comparators, all ADFs produce statistically significantly lower scores for drug liking. Mentioned as a 0 to 100 score. Oral abuse potential, the difference was between 7 and 25 points. Intranasal between 7 and 36. For Roxibond was a 12-point difference. And the similar trends were observed for take drug again endpoint. The last point is very important. There were no established thresholds for clinically important difference. There is statistically important difference. There are no clinically important difference. We have got some studies, and Ned Katz presented some of these studies in his webinar, but I think it's clear that it's likely if you have an impact on these visual analog scales, it's likely to have an impact on the abuse. It's abuse potential, it's abuse liability, but this is not a validated surrogate outcome. I think it's one of the only areas I'm aware of where an ADF approves a drug only on pre-market data. I think this can be justified by the public health crisis. But this means that the evidence for many of these ADFs is going to be very, very weak, as we're going to see. Yeah.
Can you say a little bit more about what you mean by the intranasal abuse potential data in the FDA?
Okay,
what is that
meaning
based
that
on?
in order to abuse intranasally, in order to snort, you have first of all to crush it. Right? You have to get this thing into powder.
Mm-hmm.
And then you are snorting the different substances. And then you're comparing the placebo, the non-ADF substance, and the ADF. And people are scoring how much they like the substance I just used. The word oral, it's important. It's not swallowing pills whole. The oral abuse potential is crushing. So I'm able to suck or to crush the pill. I'm going to swallow it to get the potential of the whole drug as quickly as possible. Okay. There are no studies on intravenous abuse. This was judged to be non-ethical to have intravenous abuse studies comparing different drugs. It's not being done. So the post-market studies, it's a requirement for all ADFs, meaning that according to the guidance for ADFs that have been approved in 2015 by the FDA, all drugs that get an ADF label must produce real-world evidence. The first studies to be concluded is in 2018, 2019. We did not find any real-world evidence, any post-market studies on the impact of ADFs, except for OxyContin. OxyContin, you had the situation of a before-after. So OxyContin, extended-release oxycodone, was being taken off the market by Purdue in 2010 and being replaced with an ADF formulation. So this is the first ADF on the market, and you do have studies on before 2010 and after 2010. There are no post-market studies for all the other 9 ADFs that we're talking about. So the post-market studies for OxyContin, these are all non-randomized studies comparing before-after. The comparators are other prescription opioids and illicit drugs. The major outcomes that I'm going to present is abuse, misuse, overdose, and fatality and diversion. Important to understand the data sources for that. These come from databases that include multiple entries for these data. Some of them is patients entering abuse treatment. Others for diversion, for example, it's reports by the police on diversion. So it's all poison center data, and we are lucky to have Rick Dart with us, who's in charge of the radars databases, so we can answer specific questions later on if you've got specific questions for the radar database. Dr. Katz was involved with the NaviPro, so this is database, so it's not a cohort study. Very often we're talking about observational evidence. It's a cohort. This is not a cohort. These are data points from different sources, and it's not the same patients. It's over different time periods. But this is what we have for the ADFs. Abuse and misuse, 16 studies. There is a decline in the rate of OxyContin abuse. However, some studies reported an increase in the other opioids. Other studies said that there was no change. So yes, oxycodone, there was a decrease in the abuse, but maybe at the cost of an increase for other opioids. The blue line is before, the black lines are after. So on the very left, you have got the oral abuse, crushing, chewing. So with OxyContin, the oral abuse increased and the others decreased. So the effort to get the drug out, to use it intranasally or intravenously was too high, so it moved to the other side. This is a very interesting slide. So actually they had 153 patients who they interviewed. What did you do? You had been using OxyContin, you have been abusing OxyContin. What did you do when it came on the market. So 1/3 said, well, I continue to abuse it. Another third is, well, I went to something else, I used something else. Another third is, well, I didn't take any action, I took other choices for abusing sort of, and only 3% stopped abusing drug. So this is what ADS, the impact is, it's not on the demand for abuse, it's on the difficulty to abuse a specific drug. Yes?
A question. In these post-marketing studies, was there any determination made as to how many of these were patients who were prescribed the medication versus the participants in these programs who had medication through diversion?
It's when we had a first meeting with Ned Katz, who's one of our experts, I thought, very simply, patients receiving a prescription, they are the one who've got pain and receive the prescription. And the others, the abusers, they're taking it from somebody else, diverted. This is not the case. When you have patients who present themselves to a doctor, you have a mix of people in there. You've got a mix of pain patients, different severity, different origin. You also have patients who go doctor shopping. I want the pill to abuse. It's for abusing. So it's very difficult to separate the population receiving prescription opioids from the doctor for valid reasons for pain treatment from all the others. And as far as I know, we don't have any separation about the different populations. And I don't think it's worth it. You've got all mixed up of these different populations. So abusers can abuse a drug being diverted from somebody else. They can use a drug that's being prescribed for them, but with fake reasons or whatsoever. So it's a very complex environment. Overdoses and fatalities. Yes, there are some studies, and I think the main limitation for the evidence is the quality of the data sources. This has always been the case. It's not the design. That's the best we can do with the current data sources. And what is important to understand is that if you've got other drugs, you're able to get the information from the information systems, clinical information systems. You cannot do this for abuse. It's outside the realm of clinical information systems. So the FDA had a meeting on July 10, 11th on how can we improve the data collection. But this is one of the biggest challenges on how to measure this and how to get the evidence. So rates of overdose and deaths declined. However, there are many studies showing an increase of deaths from other opioids. So is the reason showing a study that a specific rate of increase of heroin deaths that has been observed after the introduction of opioids. Others are saying, well, the increase in heroin use has been there before. It's not secondary to ADFs. But overall, there is a shift from the abuse of opioids, from OxyContin to other opioids, and a change in death rate, increase in death rates according to with these other opioids, prescription opioids or illicit opioids. Diversion, so a drug being diverted from the use. So there's three studies. These are based on law enforcement activity. So these are reports. Yes, there seems to be a decrease in diversion, but with quite a few limits on the quality of the data that go into these studies. Harms. The harms are the same for the ADF as non-ADF. If you look at the prescription use the drug as prescribed. It's the same. It's the same substance. The ADFs adds something to that, but it doesn't introduce itself as a harm if you take it as directed. So harms are not assessed in drug liability study. What can happen if you take an ADF and you chew it? If it's an antagonist in there, you may go into withdrawal, but you're not taking it as a directed. And one of the big uncertainties is that these excipients, these technologies that make the ADF and ADF difficult to crush, difficult to inject, they can produce harms when they're manipulated. So there is, with some of the excipients, and this has been one of the reasons for Opana being taken off the market, you had a substance in there that produced a blood disease when being heated and injected. You also have with Opana the fact that it was used intranasally before, it switched, moved towards intravenous. People shared the drug between them, needle exchange. So in Indiana, in the absence of a needle exchange program, you had an HIV and hepatitis C epidemic. So there are harms associated not in the take it as direct population, but in the abuse populations. The evidence rating, if you did have a look at the draft evidence report, we had the same rating for all ADFs. Due to public comments, they say, well, please be careful. We have real-world evidence on OxyContin. We don't have any for the others. So after having received these comments and discussing internally, we decided to split the evidence rating into two. The evidence rating for the individual patients taking OxyContin, we give it a C+. For all the other ADFs, we say promising but inconclusive. And we are saying the patient level, individual level, not the population level. The question is, do we have evidence to use it, and this is one of the voting questions, do we have evidence to use it to replace all opioids for which an ADF is available? The ADF is the net public health impact. The answer is we don't know because of the shift to other opioids and some harm potential. Controversies, so there are no conclusive evidence that pre-market abuse potential studies predict the real-world impact. We have neither any prospective studies in patients receiving a first prescription, ADF versus non-ADF. There is no such study available, which would have been great to have. There is a lack of good evidence on natural history of opioid abuse, and there is a lack of population-level evidence of a post-net impact of ADFs due to the shift of abuse. A very important question, which certainly will be discussed at the policy roundtable, can we predict patients at use? If you have a past history of abuse, you are more likely to get another history of abuse. And abuse can be abuse to video lottery of any kind of abuse. It's the same dopamine system in the brain. So abuse potential, if you have a history of abuse, if you have alcohol abuse, even if you abuse the nicotine, if you're smoking, you are at a higher risk. Mental health problems, past history of physical abuse, all these are predictors for patients that they are more likely to abuse. The CDC, for the 2016 guideline, did a systematic review to say, what is the validity of these different tools to predict? Are they good enough to be recommended for patients? The CDC said no. So in our report, we relied on the systematic review from 2014 to make the recommendations. We did not do a systematic review of predictive tools. That was not the object of our report. The CDC says, however, that annual urine testing is a good tool for all patients that receive an opioid. So there should be some control of patients who receive opioids, regardless of their risk of abuse. Different comments. So people are telling us there should be not public comments for the draft evidence report. ADFs are not an isolated tool in combating opioid addiction and should be evaluated in the context of a holistic program of interventions. Right? If there would have been evidence on ADF compared to other interventions, or if there would have been evidence of an ADF as part of a holistic intervention, we would have found it through our systematic review. There is no such evidence we have come across. I don't believe there is any. Some people recommended screening tools should be used. As I just said, we don't think the evidence is, as far as we have seen it, is not there to make this recommendation. And people said, well, C+ evidence for all ADFs, please be careful, and we took this into account to change our ratings. And there are some safety issues from using Opana. Over the last 2 weeks, there are quite a few reports that have come out. So there is the Tufts report in ADF, opioid development. There is the July 10 and 11th meeting from the FDA on real-world evidence. And last week from the National Academy of Sciences, there was a report on opioids. These are all consistent with our report. There is no contradiction. The report from the National Academy, for example, say be careful with ADFs. There is a potential for harm. So everybody goes in the same direction. So even if our cut-off date was May 31st, I think the evidence we present to you today is in line with all the evidence that has been published up to now. Thank you very much.
Or any comments from the clinical experts or from our patient representative? Austin.
If I'm imagining an individual who's predisposed to misuse or abuse of an opioid drug, and I had the choice of deciding for that individual, would I prefer they abuse it orally, nasally, or injected? Is there a reason to prefer one over the other? All else being equal. I know it's a different population that will go to one or the other, and that's confusing, but all else being equal, do I...
I mean, you're a physician who...
I am not, but I'm imagining I were in that position if I could choose. In other words, is there less risk of... What I'm getting at is there's less risk of harms with one route over another because of physiological reasons? Or...
I mean, the intravenous route has much more harms associated with that. Definitely. I mean, that's clear. You have got a needle that you inject.
So there is a preference for trying to push in a certain direction.
Yes, the more you advance the route, the more harmful the episode is.
Yes.
Oral, they're all harmful, of course, but intravenous is the most, followed by nasal, followed by oral. There are at least 2 papers in the literature showing that.
Very good. Thank you.
Yes.
The designation of promising but inconclusive puzzles me in the report. I can see the inconclusive side. Promising feels like spin to me, and I'm wondering where that judgment comes from.
I think the ADF for pain relief is as good as the non-ADF opioid. So I think everybody agrees on that. And there are bioequivalent studies being done. So ADF adds something to this. It can, if it's used as directed, it can only be better. It cannot be worse. For the population, it can be worse. For the individual patient, if we forget the cost, for the individual patient, an ADF adds something. We don't know exactly how much. So the FDA said the pre-market studies are a likely indicator of a positive effect. So there is a likeliness that the ADF property, the technology, adds something. It's not taking something away, it's adding something. So the adding of something, of a benefit, that's what we say promising.
Jason.
Could I just follow up to Dr. Freck's comment about the different harms from the different routes of abuse? I'm a clinical cardiologist, and a lot of us, in the absence of great data that I know of, perceive that the risk of intravenous abuse of drugs has evolved over the past few decades, that we're seeing more and more infectious endocarditis. Yeah, I'm a cardiologist, and that kind of stuff comes to me, and relatively less HIV/HCV infection. Do you think that, this is maybe another question that's sort of hard to know the answer to, but is it plausible that among the community of patients who abuse intravenous drugs, that there's more awareness now about viral infection, HCV and HIV, such that it's less risky, at least in that sense, to use intravenous drugs? And maybe the more risk now is bacterial endocarditis.
I think this can be explained, at least in part, by the needle exchange programs. So in Indiana, where Opana led to an HIV and hepatitis C cluster, this was because there was no needle exchange program. And at the FDA hearing at Opana, on the advisory committee, the question was asked specifically, did the needle exchange program that was being put into place in Indiana make the problem go away? And the answer was yes. So I think the existence of needle exchange program may explain in part why we do not observe or not observe as much as in the past the infectious risks that you describe.
Are these programs common in New England?
I think they are, but
They
I'm not.
are some, but there's not. I used to be the state health officer for Maine, and we actually were the first state in the country to pass the laws back in 1997 to allow them, because you have to allow people to obtain needles, for instance, needles and syringes at a higher amount than most laws do, and for them to be, given out for free. The challenge, and so we have 5 or 6 of them certified in Maine. The problem is there hasn't been funding for them, because when you go to policymakers to get funding, they really shy away from risk reduction strategies in general. And so I believe there are some in also located in other. I know there are some in other New England states as well, but they are on a shoestring budget and very tough. And you're out there on the streets working with a oftentimes very challenging population, but it is the door in for many of those people to get help. It's developing a relationship with them so then they can get into other risk reduction strategies and hopefully treatment eventually.
I think we have a few more questions here. Jean.
So is there any point in trying to discriminate between the ADFs that have a physical or chemical barrier and those that have naloxone embedded in them, or is just an ADF as an ADF?
I would say each ADF is specific, and I think it really is, the action is based on the way the technology is being implemented. So, for example, among the studies, one of the exclusion criteria was simulated ADFs. There were some studies saying, okay, I'm not using, let's say, Embedda, I'm using the opioid together with naloxone and try what this gives. So I think there is an intellectual property to each of the ADFs, and I think each ADF has to be considered separately. Can we say, based on the OxyContin experience, maybe we could say that physical chemical barriers are more? I don't think so. We said, let's have 2 of them, OxyContin and the others. It's difficult to differentiate further than that, I think.
Ed.
We think we've been making some progress in Rhode Island with opioid prescribing. Probably the data don't bear that out, but I'll share an experience I had about a week ago receiving reports from our prescription monitoring program that showed how I was prescribing and how other members of my practice were prescribing. And as I looked at it, I saw some of my colleagues prescribing an awful lot of opioids. And I looked at mine and I thought, gee, I'm not prescribing very many opioids. Maybe I'm not doing an adequate job of treating pain. And thinking that, wouldn't it be nice to have a safer alternative so that in these difficult interactions, maybe I don't need to be such a hard ass. And I thought, gee, I'm going to learn about some safer alternatives here, and that'll make my life a lot easier. I didn't hear any evidence of that, and if there isn't any evidence of it, I'm receptive to expert opinion on the risk of developing an illusion of safety where prescribing goes up and we make the problem even worse.
There has been a survey among primary care physicians, and nearly half of them believe that an ADF is less addictive, which it is not.
I think that's a great
So I think there are very many perceptions
policy.
out there. I think we did not look, there was some evidence on the effectiveness of prescription monitoring programs. We didn't look into this evidence. So yes, but I think generally for all the other interventions, there is also very little evidence on effectiveness. For the prescription monitoring programs depends on how they're implemented, how they are used, and what are the incentives to use them.
Any more questions specific to Reiner's presentation? Kim.
I think I just wanted to go back to Dr. Kerfman's comment, because I too have a little bit of an issue with promising and inconclusive, because I think your point about there being something added to it has to then go back to, it's only added if you believe that they're being abused. So because otherwise it's the same chemical treating the same therapeutic consideration. So I find it hard to say it's promising because we'd have to think that they were abusing the substance, and we actually have some evidence, like with the Opana situation, where it could actually be more harmful if it's being abused and cause additional harm. So I would have rather seen the rating be inconclusive.
Okay. Just maybe to say that opioids have an addictive potential. So I think based on this addictive potential, part of the population of patients who receive this for their pain are at risk of misusing it, of abusing it. So the ADF adds a property that diminishes the risk partly for this population. Yeah.
The ICER rating for promising but inconclusive, Kim, is exactly what you described, that there's evidence to suggest that therapeutically the drugs are at least equivalent. There's the possibility that there's some benefit, but there is also a small but non-zero possibility that there is net harm. So that's exactly what promising but inconclusive means. What Reiner was describing earlier is technically comparable or better, the C+ rating, where we have higher confidence that the new intervention is at least as good as its alternative. And that's not what we assign to the other ADFs other than OxyContin, if that makes sense.
I think one more question, and then we need to move on. Keith?
Yeah, question about slide 32 is the pie chart that where they interviewed the 153 folks after the switch. Now, if you just look at this at first blush, you would say, gee, the formulation had 3% of people stop abusing drugs. I was just wondering, did anybody dig any deeper into that to say, well, was it because you couldn't get it as easily, or was it more costly? In other words, were there other factors, or was this just kind of the way it was presented, and we're led to draw whatever conclusion?
First of all, one of the other effects is on street price, which is very interesting. How much are people ready to buy on the street for a drug? So what it shows, it's mentioned in the report, we don't have it on the slideshow, is that OxyContin diminishes the street price. Maybe other ADFs also. So the ADF is less desirability for these drugs because it's more complicated to abuse them. Otherwise, I don't think there is any other information I can provide on.
And the other thought I just had, which there's probably no answer, is just, in any given cohort, what is the percentage of folks that at any given time will stop using? And is that what we're seeing too?
I mean, an ADF is not a treatment for addiction. Yeah. Abuse is a behavior, and there's a need, there's a drive for that. So the ADF doesn't change anything on why people are abusing. Yeah. It's making it more difficult for people to abuse a specific drug.
Thank you. Now we'll have Rick Chapman do the economic evaluation.
Thank you. Thank you, Reiner. I'm going to briefly summarize the economic evaluation we did for ADFs. I'd like to acknowledge review team members Varun Kumar and Dan Ollendorf were involved in developing the model, and we have no conflicts of interest to disclose. Our objective for the model was to inform policymakers about the net cost and real-world impact of ADF opioids in preventing abuse. And our objective specifically was to answer two research questions. What are the potential outcomes and net cost of using ADF rather than non-ADF opioids? And what level of effectiveness in abuse reduction or in price difference would be needed for ADF opioids to achieve cost neutrality or net savings relative to non-ADF opioids? So to do this, we developed a cost-benefit model. In this model, we're looking at hypothetical cohorts of 100,000 adults with chronic non-cancer pain who are newly prescribed extended-release opioids. We took a healthcare system perspective, so in our base case, we're only looking at direct medical care and drug cost. We do have a scenario analysis where we try to bring in some other societal cost that I'll show later on. The intervention we were looking at is ADF extended-release opioids, and we're comparing those to non-ADF opioids in the same patients. We used a 5-year time horizon in the U.S., And because it was a relatively short time horizon, we did not apply discounting to cost or outcomes. So our outcomes after 5 years for the 100,000 ER opioid prescription users in our base case analysis were the number of new cases of abuse and the net health system cost. In our scenario analyses, we also looked at cost neutrality, so what threshold of effectiveness or price difference would lead to cost neutrality between non-ADF and ADF opioids in these patients. We also did a scenario analysis that you can find in the report where we included diversion. Importantly, we tried to estimate the effect of diversion, but were not able to estimate the effect of switching to heroin or other opioids. And then finally, as I mentioned, we also did a modified societal perspective where we included cost for lost productivity and criminal justice and incarceration and the potential effects of ADFs on those. We also did a variation of the model where we looked at the effects in Massachusetts specifically. And to do this, we used data from the Massachusetts Health Policy Commission on current opioid use and looked at the impact of switching all patients to ADF opioids over a 1-year time period. Here's a schematic of the model. You can see all patients start out with a new prescription for opioids, so these are people who are newly exposed to opioid use. Some of those patients will continue with therapeutic use. In the next year, they could continue with therapeutic use. They would have a risk of becoming an abuse case. They could discontinue using opioids. There's a chance of that over time, and I'll talk later about what that looked like. And in both cases, both therapeutic use or abuse, there's a chance of background mortality, and that's just based on normal age, race, background mortality. Along with therapeutic use, some patients may become abuse cases. In those cases, they may continue abuse in the next year. Each year, there's a chance that they cease abuse. There's a chance each year for overdose, and along with that, a potential for death from the overdose. We're actually able to find better information on deaths from overdose than we did on overdoses in general. So we'll actually report here on the impact on overdose death, but do not report on overdoses in general. And the main effect in the model is on this abuse pathway. So we're assuming that ADF opioids decrease the number of patients who go into this abuse pathway. Some key assumptions in the model. We have differences in rates of abuse with ADF relative to non-ADF, and those are assumed to be constant throughout the 5-year time horizon of the model. We didn't find any information or evidence on how the rates may change over time. The healthcare cost for abuse, once someone goes down that pathway, and the cost for therapeutic use are the same whether you're taking ADF or a non-ADF. The costs differ. There are higher costs associated with patients who abuse than with those who do not. But the risk of abuse is what's changing between the two cohorts, not the cost. We had the same rate of discontinuation of therapeutic opioid use in both cohorts, and we assumed an annual rate of cessation of abuse of 10% per year. These are some of the key clinical inputs that went into the model. We had a claims analysis in 2014 that looked at the rates of abuse with non-ADF extended release opioids and found about 3.7%. They also looked at patients who were taking ADF ER opioid, and the only one that was available at the time they were doing this study was the OxyContin, and they found rates of abuse there that had gone down to about 2.8%. We had an annual discontinuation rate for prescription opioid use, and you can see that that went up over time. So at the end of year 5, 40% of patients had discontinued. And the rate for death from opioid overdose was estimated to be 5.9 per 100,000 patients. For cost, we had cost for ADF opioids, and these are For both the ADF and non-ADF opioids, these are weighted average based on the market share of the drugs in Massachusetts in 2016. The cost per daily dose for the market basket of ADF opioids was $11.60. This is using federal supply schedule. We were not able to use our usual source for net cost, the SSR database, because several of these drugs are not listed there. Some are generic and some are proprietary, so were not available. So using the federal supply schedule, we get $11.60 cost per daily dose of ADF opioid, and on an annual basis, that comes out to about $4,200. For non-ADF opioids, the cost per daily dose was $5.82, which comes out to about $2,100 per year. And these are all of these doses have been converted to 90 milligram MED, morphine equivalent doses, so that they're comparable to each other. We also had annual health care costs for therapeutic use patients of $27,000 and for abuse patients of $38,000. These numbers came from the Commonwealth of Massachusetts Health Policy Commission. So when we put all these inputs into our model, these are the results we get. This is, again, for 100,000 patients over a 5-year time period. Over that time period, we estimated about 10,500 new cases of abuse would occur in the non-ADF cohort. That's decreased to about 8,200 cases of abuse for the patients using ADFs. So we're preventing about 2,300 cases of abuse over that 5-year time period. Overdose deaths go down by a slight amount, but because the numbers are so small for this cohort, it's a small decrease, 1.7 to 1.4. In terms of cost over the 5-year time period for 100,000 patients, you have savings in healthcare cost through the prevention of abuse. So the abuse patients are no longer incurring those higher costs because it's being prevented. And so you're saving about $113 million estimated from our model. But the prescription opioid cost, because you're using ADFs rather than non-ADFs, increase, and those increase about $640 million. So that in net, we end up with an increase of about $533 million over a 5-year time period. If we look at this per incremental outcome, we can look at what was the cost to prevent one new abuse case. So we're spending $533 million, but we're preventing about 2,300 cases of abuse. So that comes out to about $231,000 to prevent one new case of abuse. If you look at it in terms of the time that they're spending over this 5-year period, the cost to prevent one new abuse year is about $80,500. And to prevent one new overdose death, because it's such a small number, that becomes a very high number. We estimated over $1 billion. As I mentioned, we also did a couple of threshold analyses. This is the one that looks at changing the effectiveness of ADF opioids. So if you see the column on the left there, the 2.8%, that's our base case, where we found $533 million in additional cost. As you decrease the abuse rate with ADF opioids, so in other words, increase the effectiveness of ADF opioids in preventing abuse, you can see that those costs go down because you're preventing more abuse and preventing those costs. So but importantly, we found that here, even if we reduced the abuse with ADF opioids all the way to 0%, so no abuse if you switch over to ADF opioids, you still have a net cost of $113 million over 5 years. We also looked at what if we keep the effectiveness the same in the base case, but vary the cost difference between the ADF and non-ADF opioids. So if you look at our base case cost, as a reminder, it was $11.60. If you lower that cost down to $6.86, you would achieve cost neutrality with the situation using non-ADF opioids. So that represents a 41% change in the price from the market share weighted average that we had before. The 686, it's important to note that's still about 18% higher than the cost, the market basket cost we were using for non-ADF opioids, which was, I believe, 580 or about. We also did sensitivity analyses to look at which variables influence the results of the model. You can see here that by far the biggest influence was the cost of ADF opioids. When you increase or decrease that by 25%, you get a big swing in the net healthcare cost, although even with a 25% lower, you're still above $200 million in net cost. I mentioned earlier that we also did a societal perspective analysis where we tried to include estimates for lost productivity and criminal justice and incarceration cost. When we included those, we found cost of about $492 million over 5 years for 100,000 patients. With non-ADF opioids in the same cohort, those costs were $632 million. So ADFs were preventing $140 million in those societal costs, which when you combine with the $533 million in net health cost, would lead to a $393 million net cost from a societal perspective.
Is lost productivity only for the person abusing the substance, or does that include family members who are diverted from their usual work and whatnot because they're caring for these people or others?
Yeah, I'll have to check on that to make sure, but I believe it was only the individual who was missing work, not the family members. We also did a... Yeah.
Okay. Costs were applied to, not to the broader
Great
work.
We also looked in the state of Massachusetts of what would be the health and cost outcomes if all extended release opioid users were transitioned over a 1-year period to using only ADF opioids. And to do this, we used data from claims data analysis provided to us by the Health Policy Commission in Massachusetts using 2014 claims. And they found 113,000 patients at that time using non-ADF opioids and about 60,000 using ADF opioids. Some assumptions in this model that were different than the prior. We're assuming that the proportion of prevalent ER use is the same as the proportion of prescriptions filled. So we don't have evidence on how many people filling these prescriptions are actually taking them, but this is the assumption we made. We assumed that the prevalent use was the same as we saw in an incident population, and as I mentioned, the cost came from 2014. So these are the outcomes when we converted all patients to ADF opioids over 1 year. Abuse cases, in the current situation where you have a mix of ADF and non-ADF opioid use, we estimated about 5,200 cases, and that decreases to about 4,300 or 4,400 when you put all patients on ADF opioids, so you'd prevent about 842 cases of abuse. Cost related to abuse would go down by $21 million, but your prescription opioid cost, because you're switching everyone over to ADFs, would go up by $513 million, netting out to about $475 million increase in net healthcare cost, or a cost to prevent one new case of abuse of about $600,000. So in conclusion, in a hypothetical cohort of 100,000 extended release opioid users over a 5-year period, using ADF versus non-ADF opioids would prevent about 2,300 new cases of abuse, but at a cost to the healthcare system of $533 million, or $231,000 to prevent one new case of abuse. We could not achieve cost neutrality even when changing the effectiveness of ADF opioids in preventing abuse up to 100%. This was holding market basket prices constant. If we do allow those market basket prices to change, you can achieve cost neutrality if ADF opioids were discounted by 41% from the current market basket price. And in Massachusetts, converting all non-ADF to ADF opioids over 1 year was estimated to prevent about 850 cases of abuse at a cost of $599,000 for each case prevented. We had made some changes to our model based on comments we received in our draft report. We changed the rate of abuse to reflect the true estimate seen in the Rossiter et al. Claims analysis. We had at first actually increased the effectiveness of ADFs based on an adjusted analysis there, but when we use the unadjusted number, that's what you see in the base case now. You switched over to using healthcare costs from a claims analysis from the Massachusetts Health Policy Commission in our final report. We also added scenario analyses to look at a modified societal perspective because we had some estimates of cost for low productivity and criminal justice and incarceration. And finally, we included a scenario analysis in our report which looks at the impact on health outcomes and cost when introducing the effect of diversion based on, we didn't find a good point estimate for diversion, so we just did sort of a threshold analysis over a range. And as I mentioned, that did not include switching to other opioids or heroin in that analysis. Questions?
We can take a couple of questions before moving on. Claudia.
I have one question on slide number 50, which is the base case results when it refers to overdose deaths. Is that assuming that the overdose death is only with the specific ADF and non-ADF formulation that was prescribed, or was there any consideration of possibly patients changing to an alternative mode of abuse, such as fentanyl?
We didn't have any evidence that would allow us to really look at that, so we just took the overall overdose death rate and applied it to this cohort to come up with this. But we didn't have any evidence of whether these patients might be switching to something else before that happened.
Ed?
I was looking at slide number 51 and just trying to get a denominator that I'm used to seeing. So I was trying to come up with a cost per quality adjusted life year. If I look at the bottom row and just grossly divide by 100, thinking that each death is going to take away 100 years of life, and that's an overestimate, I'm going to get something like 1.5 million instead of 1.4 billion. Is that a fair way to think about the cost per quality adjusted life year?
Well, it's first, you're not quality adjusted. It's only
well, I'm just
life
going to
years.
say if they're dead, it's a zero, and I'm not worried about anything in between.
And as a back of the envelope calculation, it's probably an overestimate because 100 is higher than what you'd be saving there. One thing to look at too might be the abuse year there. The cost to prevent one new abuse year. Again, it's a hard metric to wrap your head around because it's not like a quality adjusted life year. But we did think about trying to do a quality adjusted analysis here. There's really not much data out there on this. And as you can imagine, it's would be very difficult to measure quality of life in this patient population, especially the ones who are abusing. So.
Greg.
Reiner mentioned, he brought up the issue that I think that some of us have been concerned about, and that is that primary care physicians might perceive ADFs as being safer. And I'm wondering if that might provide an incentive to overprescribe, and if there's any data around that, and if maybe a sensitivity analysis could be done to take that possibility into account?
We could do something like that. It would require a different sort of model, because in this model we're assuming either all non-ADFs or all ADFs. We could maybe in something more like the policy model where we had a mix, talk about changes in that mix, or look at a more population basis, look at the potential for prescriptions to change. We were starting with all new people with new prescriptions for ER opioids, so we're not looking at what could be happening in terms of the overall demand for opioids. But that may very well be an effect that's there. But we have
One
no way
more
of looking at
question,
that.
G.
So I suspect this needs to be punted to the policy roundtable, but I'm still also stuck on slide 51 and wonder if there is any comparison of cost effectiveness of prevention strategies and best ways to invest public health dollars.
That's a great question, and I think it's a perfect one for the policy roundtable. Okay. We're gonna move on to the manufacturer public comments, and also I just want to say that before we vote, if people have other questions, that they can certainly be raised at that time. Yep. I'd like the manufacturer representatives to come up to the table here.
Good morning. I'm Gwen Niebler with Eaglet, a manufacturer of abuse deterrent opioids. We appreciate the opportunity to comment today and acknowledge the immense challenge faced by ICER in conducting a review in a field that is actively changing. However, we want to express our concern regarding some elements of the report in the context of the serious public health crisis that exists. First, opioid abuse by intranasal and IV routes is not uncommon. Between 2004 and 2013, abuse by IV and inhalation increased in a population entering treatment abuse centers from 11.7% to 18.1% and 15.3% to 23% respectively, while oral abuse decreased over the same time. Non-oral abuse is also associated with approximately 2.4-fold increase in life-threatening medical events, disability, and death. Secondly, we note that ICER has chosen to consider diversion in the model only as part of a scenario analysis and not in the main model. We strongly encourage the committee to not discount the importance of diversion in assessing the value of ADF opioids. According to the 2015 National Survey on Drug Use and Health, approximately 12.5 million people 12 years and older misused prescription pain relievers, and of those, 54%, or 6.75 million people, reported obtaining their last misused pain reliever from friends and families or relatives. We acknowledge the challenges around including diversion in the model, but given the dynamics related to opioid abuse and misuse, one cannot examine this issue without including that as part of the equation. Thirdly, ICER noted in the response to comments on the draft report that since they felt there was an absence of robust data on effectiveness in preventing abuse with ADFs, and given OxyContin's current market share, OxyContin's effectiveness was adopted as the input for all ADF opioids in the model. Given this, we are concerned that there is a separate voting question around the value of the group of ADFs excluding OxyContin. We would like to point out that the approved ADF opioids are not interchangeable. Each product is different with unique abuse deterrent properties and profiles. This is supported by the Human Abuse Potential Study data tables provided in the ICER report. The absence of post-marketing data on effectiveness for some of the ADF opioids included in the review stems from them only being on the market a short period of time, suggesting that it was likely not appropriate to include them in the analysis at this time. For example, Aramo ER has only been marketed since April of this year. Given all of this, we would ask that during the voting for question 3, that the committee acknowledge ICER's position from the report that the evidence is promising but inconclusive at this time for the group of ADFs excluding OxyContin, and determine there is insufficient data to vote on the question at this time. Lastly, ICER has noted in its report that there have been publications that have suggested that when faced with an abuse deterrent formulation of an opioid, abusers may switch to other routes of abuse or other forms of opioids such as heroin. We would urge the caution in using Opana as an example of this, since Opana is not an abuse deterrent opioid and was never approved by the FDA with labeling for abuse deterrence. It is also important to recognize that the outcomes are influenced by many considerations beyond the ADF opioid itself. The continued availability and prescribing of non-abuse deterrent formulations and easy availability of cheap heroin all allow for a path of least resistance to be open to an abuser and informs what the abuser does when faced with an abuse deterrent formulation. We believe that tackling the opioid epidemic cannot be accomplished by one approach alone, and the model presented is not able to take into consideration the additional harm reduction that could occur if multiple simultaneous approaches were applied to the problem in a preventative health approach, such as use of ADF opioids coupled with responsible prescribing, proper storage and disposal, use of prescription monitoring programs, and intergovernment agency collaboration to address illicit opioids. Thank you.
Thank you. Can someone comment on the point that when made on the third question of ours, in terms of the excluding the ADFs, excluding for concern there? You had a concern about our third question, correct?
Yes.
So did you want to summarize that quickly and
Yeah,
what your concern is?
Sure. I think if you go to the third question, or with the revision of the questions for the voting committee, it parcels out a question about OxyContin, and then the third question is about ADFs besides OxyContin. Our concern that the model just used input from OxyContin, so really that you're just voting on the same data in two different questions, essentially. And the point being that for several of the ADFs that are being voted on, there could not be any post-marketing data because some of them were just approved very recently and not on the market until the past couple months.
Thanks. I guess, so the voting question, I apologize, the audience can't see them right now, but the voting questions are focused on the evidence on comparative clinical effectiveness. So the model, while sometimes it can be informative, there are not any questions about the value relative. So the question was really to split out, and we did receive public comment that it was important to split out a vote on OxyContin, for which there is a body of evidence, versus the other ADFs for which there is not yet. And when we say that there's inadequate evidence, or when they would vote that way, it does often mean that the evidence just is not present at this current time. However, for decision makers across the board who are making both clinical and legislative decisions about the existing batch of non-ADFs, we felt it was reasonable to have a question about them as a group, with OxyContin having its own separate question.
Thank you. I'd like to introduce Sunny Cho, Director of Medical Affairs at Daiichi Sankyo, and if you could state any conflicts, please.
Yes. Good morning. I'm an employee of Daiichi Sankyo. On behalf of Daiichi Sankyo, thank you for the opportunity to provide comments on the ICER report on the abuse deterrent formulations of opioids. We'd like to thank ICER for bringing attention to the problem of opioid abuse, for recognizing the value of ADFs, and for their extensive work in preparing the report. The national opioid crisis is complex and there is no one single solution. ADFs offer healthcare providers valuable tools in the fight against the potential for misuse and abuse, while at the same time providing patients relief from their pain. While ADFs are designed to reduce the risk of abuse, they are not abuse-proof and are not expected to eliminate the risk of abuse. The FDA considers ADFs an important part of their opioid action plan and conducted a workshop on July 10th and 11th to discuss data and methods needed for evaluating the intended impact of ADFs on misuse, abuse, addiction, overdose, and death in the post-market setting. We acknowledge that most ADFs do not have the duration or market share to allow demonstration of such data at this time. A person who misuses prescription opioids may start by swallowing the intact pill, but some will go on to crush, snort, or inject the drug, which is concerning as these are the most dangerous routes of abuse. Data from the RADARS system found that the relative risk of death or a major life-threatening effect such as overdose relative to a single instance of oral abuse is 2.2 times greater for each instance of intranasal abuse and 2.6 times greater for each instance of IV abuse. Abuse and misuse of prescription opioids is not limited to just patients. As noted in the FDA workshop, non-medical use of prescription opioids by those who are not originally prescribed them is also prevalent. Data from the 2015 National Survey on Drug Use and Health found that opioid diversion is widespread, with more than half of abused prescription pain relievers obtained from a friend or family member. The survey also found that obtaining pain relievers from a friend or family member was the most common source for those who initiated misuse in the past year. As cited by ICER, there is some data with OxyContin and its impact on diversion. OxyContin diversion fell by 53% 18 months after the introduction of the reformulated version, and Severton et al. Found that 5 years after introduction, diversion of OxyContin fell by 89%. And in another study, Copland et al. Found that diversion rates of OxyContin declined by 66%. We believe that by reducing diversion and progression to advanced forms of abuse, ADFs can also reduce the burden of associated costs. We support taking proactive steps to build a scientific base and framework to assess the intended impact of ADFs. That information is important and necessary to make the ICER report complete and guide therapeutic decisions. It will also improve our oversight of opioids for the good of public health. We believe the baseline analysis in the ICER report is incomplete as it does not consider the impact of ADFs on the friends and families of patients and others in the community who are misusing and abusing diverted supplies of prescription opioids. Daiichi Sankyo stands by the value of ADFs as part of a comprehensive approach to addressing the opioid epidemic. We look forward to bringing Roxibon and Morphabon ER to the market in the coming months, thereby giving health care providers additional valuable tools in the fight against the potential for misuse and abuse, while at the same time providing patients relief from their pain. As part of our post-approval commitments, we will be collecting data that would assess the real-world impact of Roxibon and Morphabon ER. Thank you.
Thank you. I think I'm going to move on to Dr. Main, and then I'll have Dr. Rick Chapman come up and talk about the diversion issue. Dr. Main?
Good morning. My name is Dr. Tracy Main, Head of Medical Affairs Strategic Research at Purdue Pharma. The topics we're discussing today are timely, important, they're also complex. Your decisions have the potential to improve or worsen both the societal impact of opioid crisis and the health outcomes of patients who are living with chronic pain. Today's analyses and models and the decisions they drive must undergo the highest levels of scientific scrutiny, balancing between the appropriate pain management for patients who are suffering and the decreased risk of diversion and abuse. It's unfortunate that ICER missed the opportunity to fairly evaluate the impact of ADF opioids. The FDA, DEA, NIDA, and many other policymakers recognize that innovative ADF technologies are an important component of addressing the opioid crisis. I want to be clear with you, though. ADFs are not a standalone solution. They do not treat opioid abuse or addiction. The active ingredients in ADFs and non-ADFs are no less addictive than each other. That being said, ADFs are important enough that FDA Commissioner Scott Gottlieb just last week said the FDA strongly supports a transition of the current market dominated by conventional opioids to one in which the majority of opioids have meaningful abuse deterrent properties. The data used to inform these healthcare decisions must be reviewed fairly and independently, but ICER's reports are not peer-reviewed and they're not subject to government or institutional oversight. ICER decided early on to limit the review to OxyContin. The reason was quite sound. It's the only ADF with sufficient utilization and published research to allow for a review. ICER presented its first model based on the published scoping document, published model analysis plan, and scientific feedback to members of the scientific community on February 22nd. ICER reported OxyContin was cost-effective at $20,000 per abuse case avoided. Now, ICER doesn't publish its results in peer-reviewed journals, nor does it release its models so they can be independently validated. So we engaged a nationally recognized expert, Dr. Ed Pizzala, former national medical director at Aetna, and using ICER's public documents, we were able to closely replicate their model. Next, based on scientific input, ICER corrected a number of errors in their initial model. ICER mistakenly used the wrong comparator cost for the comparator drug, so we provided the correct FSS cost. ICER used a 20% diversion reduction in the model just as a placeholder. They said they didn't have the scientific literature at that point, so we shared all the scientific literature showing that ADFs reduced diversion 57 to 89%. Dr. Pizzala and ICER then revised their models. They updated them with these data, correcting these errors. At our request, ICER then reviewed and validated Dr. Pizzala's findings. Most noticeably, at this point, OxyContin saved commercial payers $208 million among 100,000 new ADF users over 5 years. The results differed from ICER's own model by only 1.4%. Their model showed massive cost savings. Prior to submitting these results to peer review, we gave ICER a copy of the paper and we solicited their feedback. After extensive independent peer review, that manuscript has been accepted for publication, and I encourage you to read it. It's titled, Understanding the Value of Abuse-Deterrent Opioids to Commercial Payers, Learnings from the Institute for Clinical and Economic Review Economic Models. What happened next is noteworthy. 2 weeks before the preliminary report was released, after 8 months of external scientific input and collaboration, ICER completely changed the basic model structure and its inputs, attributing those to feedback from unnamed sources. The subsequent model, created with no public scoping, no public analysis plan, and no scientific review, concluded ADFs were not cost-effective. It's my impression that these changes were made because the model didn't support ICER's predetermined conclusion. You see, ICER had run sensitivity analysis on that initial model, and it knew that it was highly sensitive to 2 variables: the difference in ADF and non-ADF costs and diversion. Regarding those ADF and non-ADF costs, ICER changed the model from an OxyContin-specific model to an ADF market basket model. This is really problematic. First, ICER extrapolated those 25 studies, they were all OxyContin-specific studies, to all ADF opioids. FDA has clearly stated comparisons among the ADF technologies cannot be made at this time. Why would you think that adding a polymer to an opioid and adding naloxone to an opioid would in any way have the same impact? ICER itself previously stated in its own documents that the real-world evidence only exists for OxyContin and should not be generalized to other ADFs. Yeah. Second, the market basket model used an unspecified formula to create a price applied to all ADFs and a price for all ADFs, maximizing this cost differential. I have just 1 more minute left if I could be allowed to finish, please. Next, ICER removed diversion from the model, even though 60% of their submitted public comments said that diversion should be included, and there is not one single public comment saying that diversion should be removed. That scenario showed that a 35% reduction in opioid diversion renders their model cost neutral. Anything above a 35% reduction in diversion makes their model in their report cost savings.
Dr. Main, we need to move on.
By changing these 2 variables, they added $700 million to that model. This is all done at the last minute with absolutely no input. Our concern is not the model conclusion, it's that they subverted their own scientific process to get to that conclusion.
Thank you, Dr. Main. I'd like Dr. Chapman, Rick Chapman, to discuss just a couple of why the divergent is not part of our model, and just, again, review some of the changes made to the model and why that happened.
Yeah, there are a couple of slides I could potentially show on this. The reason we took diversion out is because we could not find a good point estimate for what diversion would be in the cohort that we're looking at of patients with new prescriptions, how much of that would end up being diverted. We looked for that. We had used placeholders in our preliminary model, but none of those were really fit for purpose for what we were looking for. We did, though, include a scenario analysis where we looked at the risk of diversion, and I'll go back and show that slide. The other issue we had was, yes, there's diversion, and we weren't able to find a good point estimate for that. The other thing we were not able to find is how diversion and the switch to other opioids or heroin play off against each other. And so you can think of that as there may be a decrease in diversion, but it may be offset by switching to other opioids or heroin, and we had really no good data to look at that.
This is really important because it's an error in this report that's really significant. Switching and diversion are two completely different things, and you conflate them in the report. Diversion is I'm an opioid user, and my drugs somehow make it into your hands. That's diversion. Switching is I am an opioid abuser. I no longer like this new formulation, and therefore I switch to something else. They're completely separate concepts, and you just conflate them throughout your report.
We don't conflate them. They're two separate concepts. We, however, don't know how the two play against each other in any situation.
Why would the diversion of my opioid have anything to do I'm a regular user and it's being diverted to somebody else. What would that have to do with her being an abuser and not liking that anymore and going to something else? They're not related.
So someone who gets a drug through diversion and is no longer happy with that drug may switch to something else. We did look at diversion in a scenario in our scenario analysis in our report, and here's a slide showing that. This assumes that there are 1.25 cases of diversion for every abuse case that we saw. And if you make that assumption, you can see over at the 0% decrease in diversion, that's our base case where we did not include diversion. The base case cost was around $533 million, as we reported. As you decrease the risk of diversion, so you're reducing diversion, you can see those costs go down. So, for example, if you reduce diversion by 20%, the cost would now be $232 million in net cost. And as Dr. Main pointed out, if you reduce that diversion by 35%, you achieve cost neutrality. So if you believe that the diversion will be reduced by more than 35%, then ADFs would be cost saving under this scenario. You can also see in our report, we ran the similar scenario with one case of diversion per abuse or with 0.75 cases. And there, because you have less diversion happening, you have to get to a higher percentage reduction in diversion to achieve cost neutrality. But even at the 0.75, I believe it was around 57% reduction in diversion would achieve cost neutrality.
Teresa? I know we have to move on to public comment, too. So we have public meetings, and part of that public process is to hear stark differences of opinion, so we fully appreciate that. I just wanted to run through a couple of the things. One is that ICER does publish its models.
It does not peer review its models.
Yes, we do peer review our models, and we submit them to publication. I'll provide them to you. Yes, we do.
Oh, so this is being peer reviewed?
Sir, would you let me make my comments, and then I'll invite you to respond?
Absolutely.
This will be peer reviewed. It will be submitted for peer review. We do that with our models as part of our report process. As far as diversion, and I know that I think you had a misunderstanding about how our process works, which is unfortunate, because we do follow a process in which we take input and feedback at multiple points throughout almost an 8-month period from many different stakeholders, not just the manufacturer. The manufacturer is a very important voice in our process, and we listen to it carefully, but it's not the only one. Relatively late in the process, we discovered that we felt we had made a significant flaw in the basic approach, which was, if you think of diversion as a potential benefit of ADF opioids, to be realistic, you have to consider the potential downside of switching to other forms of abuse, including IV heroin, fentanyl, other opioids. It's not fair in a modeling perspective to just give the potential benefit without also considering the potential downside And we were trying to do that. So it felt completely imbalanced to give the benefit of diversion to ADFs and to somehow not consider how that scale really works. And as you know, published evidence has suggested that there's an increase in deaths associated with the introduction of OxyContin into the population. We chose not to use that as the base case, which probably would have been our base case, which would have actually shown that ADFs caused more deaths and higher costs. We chose not to choose that and instead to take diversion out and to make it quite clear that our model does not include diversion because of the completely difficult to assess and possibly very negative impact of the overall balance in the population with that. So that was our reasoning, and the timing was late in the game because we were continuing to think about it and to get input from multiple different stakeholders. And as soon as we had made that decision, we shared it with you.
Where is that public, because you publish all of the feedback, we went through all of your published feedback. So where is it in the published feedback that was an issue?
I do not know if it was actually sent as a public comment in a written
So
form.
there are private feedback that you get as well as public feedback?
From you as well as from others. We have phone calls that are not transcribed. We had multiple phone calls with you and other manufacturers which were not transcribed. Yes, we do take public comment in multiple different ways, not all of which arrives at our desk as a written letter. I'm sorry. So let me just conclude by saying we need to be fair to the others who wish to make public comment. I believe you have a consultant who also wishes to make a comment. So, Teresa, I have to hand it back to you, but I know we're already running behind.
But there's one thing
time.
that has to be addressed, Steve.
Dr. Main,
You said
Dr.
actually
Main,
in your scoping documents you weren't including
Dr.
heroin
Main, we're going to
very
have to ask you to
specifically because this was not an addicted population. So you literally said that's why you weren't including heroin. You made a very compelling reason why.
Dr. Main,
and now you're
Dr.
contradicting
Main,
that completely.
Part of the civil discourse is being fair to others who have time to speak. So let's let those other commenters come up to the table, please.
Part of civil discourse is also decent science, Dr. Pearson.
Teresa.
Okay, I'd like to invite the other public comment. So, yeah. So we're going to switch seats now, and we'll have the Shayna Smith, Ed Pizzala, Dan Cohen, and Dr. Richard Dart come up.
And we'll have the public commenters presenting from that standing mic over there in the order of the slides.
And again, if you could indicate any conflict of interests.
Do you want me to wait so I can see the timer? Okay. Because I'll take like half an hour otherwise. Thank you. What's that, 10?
It's 10 minutes.
Oh, okay, thank you. To the members of the New England Comparative Effectiveness Public Advisory Council and the attendees, I'm Shayna Smith, Director of State Advocacy and Alliance Development with USPN, as I stated earlier, but I'm also a person living with incurable and a rare chronic pain condition. U.S. Pain Foundation does support abuse deterrent formulations, ADFs, as an important step in deterring abuse and creating safer opioids. While prescribing opioids are an important component of pain management for varying chronic patients, abuse and misuse of these products have resulted in too many injuries and deaths across the United States. ADFs do present a step forward in removing the problematic effect of opioid use and thus its appeal for abuse. As an organization founded by people with pain for people with pain, we were discouraged to learn that the ICER report did not view ADF technology as a way to help put a stop to the unnecessary abuse of critical medications. Diversion mechanisms such as ADFs takes away the unintended and current issue of penalizing those who have legitimate need for pain relief. While we understand ADF meds are not the only tool that should be used to stem the rising tide of prescription drug abuse, the technology should be on the front line in that fight. The FDA and other federal agencies have publicly stated that ADFs can aid in deterring abuse, misuse, and diversion. And what ICER's draft report failed to recognize was the direct impact that such findings will have towards both stigmatized populations, those with addiction disease and those with chronic pain disease. We cannot ignore that opioid abuse are realities that affect legitimate chronic pain patients, their families, physicians, our society, and overall healthcare system. As an organization that supports restricting access to those who are unfortunately abusing while keeping those in compliance away from stigma or penalties, it's alarming that the report did fail to recognize benefits of reducing diversion. While we appreciate the opportunity to review the draft evidence report, it does lack some data noting unintended outcomes that such recommendations will have towards patients. It also fails to fairly weigh the balance between costs to prevent addiction disease and costs to treat addiction disease. Those living with chronic pain don't seek medications, whether opioids or OTCs, to combat their relentless disease of chronic pain. What we seek are answers, support, and quality health care. Patients should be in the driver's seat when it comes to their treatment plan with guidance from their clinician. And as a person living with a debilitating and curable pain condition, we should have the option of taking ADFs if he or she was previously taking or was advised to take an opioid by their healthcare team. As a mother with a rare and curable chronic pain condition, I'd like to just briefly share my concerns should ICER have its final recommendation mirror this draft report, because such a document will then be fully supported and embraced by insurance companies and pharmacy benefit managers. I was born with faulty collagen, which is the glue that holds us together. Ligaments overstretch. I experienced many dislocations called subluxations. My muscles are overworked to compensate for the elasticity in my ligaments. They're working really hard right now just to stand here before you. At some point during my chronic pain journey, if I've exhausted all other therapy options, complementary, holistic, and other types of approaches, and I've looked at even possibly trying prescription medications and have failed for one reason or another, I would like to remain a contributing member of this society, and so it's only ethical that I be provided with all available options. And by provided, I'm also including fair health coverage under my insurance plan. And such available options would include ADFs. I have a 7-year-old son who also has the same painful and trying condition. It's known as Ehlers-Danlos syndrome. So should I enter the point in my chronic pain journey where I've exhausted all other means of treatment therapies and I need to try some sort of medication with opioid components, I'd feel most comfortable in selecting ADFs. I could not live with myself if my condition warranted the taking of a medication and then accidentally fell into the possession of my son, despite safe storage of my prescription, causing him bodily harm in any way. It's my right to keep my family safe. It's my right to manage my chronic pain. Of significant concerns the weight that ICER's final report will have in the state regulatory arena. It's my privilege to keep track of legislation across the U.S. that impacts chronic pain patients, and we did see a handful of bills this year that would require insurance companies to cover at least one ADF without any additional stipulations. So while we remain cautiously optimistic and recommend that ICER goes back to the drawing board before presenting inconclusive data in any way ADFs impact the chronic pain community, it appears that we as patients may be faced with an inevitable uphill battle. Should the final report remain status quo, insurers will gladly interpret this document as law of the land. Companies will argue it doesn't have to cover ADFs to its enrollees, despite the technology's promising outcomes. From the perspective of the chronic pain patient, coverage to access to ADFs is not a privilege, it's a right. We have the opportunity to be proactive rather than reactive and tackle prevention instead of addiction, yet the draft report appears to misconstrue some statistics relating to drug switching to make snap conclusions. The U.S. Pain Foundation is recommending more time and additional perspective from the chronic pain patients and consumers that they be factored into this equation. It's also unfortunate that I'm the only person here, and I'm sorry if I assume that is representing the chronic pain population today. We further recommend the study into insurance coverage policies include data from legitimate chronic pain patients. We all know a lot of the statistics that is estimated 500,000 people could die from overdose over the next decade. We're currently spending $36 billion per year on addiction treatment, but yet only 10% of the estimated 2.2 million Americans living with addiction disease have actually received addiction treatment. Opioid-related issues do take away about $80 billion per year from the economy when you look at productivity, criminal justice, and healthcare costs. So I'm asking, why are we not looking at prevention, and instead we're fixated on the immediate upfront costs to insurers by having to cover ADFs, medications that can curb and deter individuals living with addiction disease from having access to prescriptions that they can abuse and misuse? When the FDA is urging companies to make abuse more difficult, when there's an alternative option that makes it more difficult to manipulate by crushing, breaking, and passing it through a needle, and when clinicians like Dr. Jeffrey Gooden, Director of Pain and Palliative Care at Englewood Hospital in New Jersey, says such medications can offer clinicians a new approach for treating patients in pain while also fighting against the potential for abuse, we must listen. Thank you.
Thank you, Shana. I'd like to invite Ed Pizzala up. And again, state any conflicts that you may have.
Great. Yes, thank you for this opportunity to address this issue. I'm Dr. Ed Pizzala, formerly Vice President for Pharmaceutical Policy and Strategy at Aetna, and now an independent consultant to pharmaceutical manufacturers on matters pertaining to insurance coverage and health policy. I have an ongoing consulting relationship with Purdue Pharma. I am the lead author on a soon-to-be published paper on this topic, as mentioned by Dr. Main earlier today. With regards to a model examining ADF of long-acting opioids, can the societal and payer views be reconciled? I think an important question, since payers will look closely at the findings of this and other groups in guiding them in terms of coverage for abuse deterrent formulations for opioids. And I do believe that we can reconcile both a societal or public health view and a payer view. The societal view is a broad one that includes both concerns for individual patients and for those around them. Just as in a contagion model, what happens to one person can influence others. In this case, the influence is access to opioids through diversion. That is, one person has them, others may be able to take them. The impact of ADF opioids on someone already using and perhaps abusing opioids may be somewhat limited. However, limiting the opportunities for abuse of the drug may reduce illicit use by others. ADF opioids may reduce abuse by some patients who are already taking opioids, but it's this impact of reduced availability of opioids on those who are not yet abusing or perhaps in any way using opioids right now that is important. At first glance, it would appear that payers would be concerned solely with the individual patient and not so much concerned with those around them. However, insurance is actually a group event. The usual unit of commercial insurance is the family, including children and right now young adults up to age 26. Additionally, a given payer may have a high concentration of members in a given geographic area due to employment and other social patterns. This exposes the payer to public health issues at the community level. So in conclusion, diversion of opioids beyond the individual who has been prescribed the drug is both a community and a payer issue, and one that is in part addressed by abuse deterrent formulations and should therefore be considered in any economic or policy discussion. Thank you for your attention.
Thank you. I'd like to invite Dan Cohen up. And if you can state any conflicts.
Thank you. My name is Dan Cohen. I'm an officer and executive vice president of ChemPharm, a biopharmaceutical company that makes prodrug technologies for the treatment of pain, ADHD, and CNS disorders. I'm also a board member of the MedStar hospital system in the Mid-Atlantic, where I serve as the vice chairman of the board of the National Rehabilitation Hospital and a board member at the Colorado-based Keystone Policy Center, which is doing research in abuse deterrent technology. I'm here today as the chair of the Abuse Deterrent Coalition. It is a 30-member organization formed as a talk group that is comprised of ADF technology innovators, patient and issue advocates, and research groups. Our intent is to educate the public, policymakers, and the FDA on the importance of developing and expanding access to ADF technology. The 19 innovative members in the coalition have produced all 10 FDA-approved labels for opioids and have on file approximately 85% of the NDAs and INDs that are pending before the agency. The primary question before ICER today: is it reasonable to approve abuse deterrence technologies as cost-effective at this early life cycle stage? Not surprisingly, the data presented by ICER for consideration, at best, to me, is incomplete, and it makes assumptions inconsistent with the technology itself. As this panel should be aware, existing products with ADF labels have largely attempted to make products more resistant to tampering or less rewarding for abusers. It is an early intervention technology. ADF does have a role in fighting prescription drug abuse. ADF is the most substantial contribution to the fight against prescription drug abuse that pharmaceutical manufacturers can offer. And ADF is but a single tree among many others in a forest necessary to fight this battle. As this panel prepares to answer the economic questions under consideration, it is important to ensure that we are using appropriate and similar terms for this discussion, and I am concerned that we are not. As our members and the agency, along with expert panels such as this one, have grappled with fundamental issues, one key concern has been both nomenclature and expected outcomes. Having different understandings of the terms being used will yield a faulty decision and not appropriately address the questions that are before you today. Those concern basic course concepts, such as abuse deterrence, and who is the customer or the target of ADF technology. In a self-evident and silly example, and I don't mean to insult the panel, but if you were to run a million-sample Monte Carlo scenario analysis on the ability of abuse deterrent technology to deter the ability of the North Koreans to acquire nuclear offensive capabilities, you would be insulted because it has nothing to do with the technology. And yet the cost-effectiveness analysis that is being used today feels somewhat disconnected from reality as well. If a non-intended outcome is the basis of the analysis, the study itself becomes fatally flawed. So first term, ADF. There are many real and potential attributes of what is ADF, what it can do, what it can be expected to deter, and what might be a reasonable hope for technological advancement. What should not be under consideration today is ADF capabilities as an abuse prevention formulation, APF. There is no APF. Products with ADF technologies do not and are not expected to prevent abuse of scheduled products, only to lower, through deterrence, the abuse potential of the products. Innovators in the ADF technology want to and will do more with those technologies over time. But the question that we ask as a community, and you should consider, is will we support the science that is possible today and not wait for what we hope will be a technology tomorrow? Technological feasibility is why intranasal and intravenous abuse deterrence is a consideration, and oral abuse deterrence is an aspiration. ICER's measure of the abuse prevention abilities in its cost-benefit analysis in factoring abusers deterred from continuing their abuse is a misapplication of the technology. The development of abuse deterrent formulations is part of a multifactorial effort to reduce the risk of abuse and diversion. Neither abuse prevention formulations or oral abuse deterrent formulations is technologically feasible today, even as both are aspirations in the remaining goal of the innovators. Every step we take in improving technologies that are possible today makes development closer to the goals of tomorrow. And as we achieve therapies for patients while making abuse, misuse, and diversion of important medications as difficult as possible within the bounds of known science, ADF is getting more effective. But we will not get to future innovation by failing to pay for current discovery. So the second term, customer. To give full meaning to this, it is important to agree on that term. Who is the customer for ADF? And that is what I believe is another failing of today's model. We have different notions of who ADF is expected to provide the public health benefit. Most of the discussion, data, and anecdotal stories reviewed and available to ICER in its formulation on ADF focus primarily on the addicted or the critical abusers of the drug. Those were the studies that were presented earlier. Abuse deterrent technologies, ADF, is best understood as a technology that reduces the risk of misuse and diversion by focusing primarily, to the point of exclusion, on the opiate naive and the early stage recreational abusers. ADF is not a technology capable of effectively deterring a professional manipulation, a desperate addict, or a highly experienced abuser. Extended release formulations are ultimately not our target, but it's the immediate release products. As of 2015, the most recent data I have available, there were 8.8 million scripts for extended release products. Nearly two-thirds, about 64%, have an abuse deterrent technology. At the same time, the entry-level products, immediate release formulations, there were 240 million scripts available. Not a single one of those products have an abuse deterrent technology in it, yet those are where we can have the most impact. ADF is an early stage intervention. It is one tree in a forest of effort to reduce prescription drug abuse, a tree in the forest that does play a key role in deterring people, children, from starting on the path to addiction. It is not a silver bullet, but it is a fundamental core principle in establishing the public health benefit. The success of today's technology will be measured by reductions in rates of misusers and abusers that are deterred from progressing or starting ever more aggressive forms of abuse. That is the true goal of ADF. As a recently published paper, on which Dr. Dart, who we'll hear from shortly, is a co-author, demonstrate, the risk of a serious safety event or death is at least 2.5 times greater when misusers and abusers progress from oral to intranasal and intravenous abuse. If we can interrupt that progression, we have a public health benefit. The focus today is on ER, but our focus is on IR. As you consider the recommendations that you're going to vote on, we urge you to seek not to make the perfect the enemy of the good. Our joint job today is to discuss both the existing science and what is needed to properly assess the impact of opioid formulations with abuse-deterrent properties on misuse, abuse, addiction, overdose, and death. As confirmed earlier this week by the Commissioner of the FDA, the agency strongly supports a transition from the current market dominated by conventional opioids to one in which the majority of opioids have meaningful abuse-deterrent properties. I've been in the public policy side of abuse deterrence arguably longer than anyone else in the industry, having the first meetings nearly 18 years ago. In 2011, 3 state legislatures examined the question of abuse deterrent technology. The end of last year, it was up to 39. Federal legislation is under current negotiation right now in the health subcommittees. Let's make sure that we don't focus so far in the past that we forget what's going on in the present. Abuse-deterrent formulations do have a burden of proof, and I do believe that they have met that burden of proof for what they are capable of, not what we hope them to be. It is deserving of a favorable vote when you get there later today. I will be on the panel this afternoon and be happy to discuss any of these issues in greater detail. Thank you.
Thank you. Dr. Richard Dart.
Hi. First, I want to thank you. I'm a scientist, and I didn't realize that I couldn't have slides, so we got to compromise. You're good paper. But that's fine. And so my name is Richard Dart. As you've heard, I'm the director of the radar system. We are supported. I'm part of Denver Health, and we're supported by both the pharmaceutical industry and governmental agencies that fund the program. If you would go to the bottom left of the first slide, and the numbers didn't show very well on these slides, I want to talk briefly about the progression of prescription opioid abuse and the concept that if you take the patient group that ICER is considering, which is an appropriate one, the adult non-cancer chronic pain patients, newly prescribed ADF or a non-ADF, a certain percentage of those will be susceptible patients, and they will develop a substance abuse problem. I've shown some of the tools we can use there to prevent them from going into the balloon, if you will, of prescription drug abuse, and shown the role of ADFs, which is primarily to help them resist the temptation to manipulate a drug in order to speed up its effects or intensify their high, and avoid those outcomes, which are the FDA-defined outcomes, or not all the outcomes possible. So we were curious about whether there's evidence to support this, and you hear people saying both sides of this issue all the time. So we did a systematic review addressing the question is, does the introduction, this is now the fourth slide, lower right-hand corner, does the introduction of an opioid analgesic with abuse-deterrent properties result in reduced overall abuse of the drug in the community? And we used only the opioids, of course, that have that labeling. And these are structured and presented using the Bradford-Hill criteria. Upper left of the second page, we'll just go through a few of those criteria since of limits of time. In terms of strength or effect size, the effect size is really quite impressive. Reduction in a variety of indicators went down from 27 to 90% after the introduction of OxyContin. As everyone said, this is focused mostly on oxycodone ER because that's where all the data are. If you go to the right upper corner, then we look at consistency as a factor, or reproducibility. And that was also quite striking because you see the same measures of abuse being measured in 3 different countries. And in all cases, it went down. And this is the U.S. in 2010 for OxyContin, 2012 in Canada for OxyNeo, and 2014 in Australia for OxyContin, again, is the name. Those are all the same product, actually, just different names. Lower left-hand corner, we have specificity. And this is particularly interesting because I'll show you another slide on this, but it really does seem to be specific to OxyContin. When we look at reasonable comparator drugs, they were consistently different from the reformulated oxycodone ER. Lower right-hand corner of page 2, we have temporality. And the temporality is also striking in that these changes occurred promptly after the introduction of OxyContin and in contrast to increases in the other opioid analgesics. Next page, page 3, please. Upper left-hand corner, the highlighted areas now, we're looking at confounding or bias. This is not one of the Bradford Hill criteria, but this is a big issue in post-marketing surveillance data, always is for every drug, and so we have to address it. And this is a long presentation to really get into it, but we did not find an alternative explanation that plausibly explains similar decreases across at 3 different time frames in 3 different countries. Just to give you a couple of examples, upper right-hand corner, and this was a build, so I can get the message across, but this is from the RADAR's opioid treatment program, and these are people telling us what they abused in the last 30 days when they entered treatment for substance abuse. These data come from 115 substance abuse treatment programs in 37 states across the U.S. That red vertical line where it says reformulation is when OxyContin was introduced. The black solid line is OxyContin. The black dotted line is all the other Schedule II opioids combined. Interestingly, what we saw was a marked decrease in OxyContin with a neutral to increase in the other opioids, and this was over the first 18 months. And the part of the line that you unfortunately can't see because of the build is that then both lines start going down, which raises an interesting perspective to me, which is I think the OxyContin effect is there in the first 18 months, and after that, when the lines are parallel, we're seeing the effect of other interventions like PDMPs and all the other things that have been done to reduce prescription opioid use and abuse in the United States. Lower left-hand corner, we're now looking at non-medical use. This is not technically abuse. I think it's related, but in the National Survey of Drug Use and Health. An interesting pattern there where we see endorsements of OxyContin specifically, they do have a question on that, go up until 2010 when the reformulation occurred, and we've seen decreases every year since then. Moving to the right lower quadrant, we have the data from the Sydney Medically Supervised Injecting Center. Fascinating paper from Louisa Degenhardt, who does a lot of work in this area. And at reformulation, you can see that the top red line, which is all oxycodone injection, just injection, went down. At the bottom right, you can see a little red line that is the reformulated OxyContin. However, we did see some increases in heroin and morphine there. Those are the blue lines. Now, last page, page 4. Upper left-hand corner, this is another RADARS program, drug diversion program, and these are investigators who are investigating drug abuse, and they're reporting what drugs have been involved in their busts in the past 30 days. This is 250 investigators across 49 states. It's a very similar pattern, a decrease in OxyContin, which reached about 75% that's unfortunately under the build, you can't see it. But again, all the separation occurred in the first 18 months. Upper right-hand corner, which gets at this diversion issue, I think, a little bit, although that's not why I put it in, but since that's become a hot topic, this is just a simple opioid analgesics prescriptions dispensed in the United States. The dark line, again, is OxyContin, and you see a prompt decrease after its reformulation, which I believe is due to people, doctor shoppers basically, or pill mills, together stopped using OxyContin because that wasn't the drug that they wanted anymore, and we saw this remarkable decrease during that time, in contrast to an increase in the other drugs. So lower left-hand corner, which I think probably agrees with most people here, but to me, I think ADFs are needed. I think the data, to me, are overwhelming. I've given you a taste of it here, but there's 44 studies now we're talking about, folks, and across 3 different countries at 3 different time frames. It's hard to say that it doesn't work. I do feel that all opioids on the market should be abuse deterrent. That's what I want to prescribe if I'm treating chronic pain. But it's part of a system, and I think that's the most important thing, and FDA's recently recognized this with their new REMS proposal, and that is we need to educate prescribers so they use other modalities whenever possible. That alone would decrease prescribing a lot. Appropriate screens, which I think are a bit more effective than might have been presented earlier. But when we get to the person who actually needs it with chronic pain, we want an ADF because we want to discourage improper use of that drug. And then once they're on a treatment, we need PDMPs and urine drug testing, for example, to make sure that they're on the right course and we detect them if they develop abuse behaviors. The diversion aspect, I think, is quite important, and as mentioned earlier, I was going to close with that. Another thing we observed, I didn't put the data in here, was this marked decrease in the street value of OxyContin as soon as it was reformulated in 2010. So thank you for your attention.
Thank you very much. Any questions for any of the public commenters? Okay, well, thank you. We'll break now for lunch, and we will start right at 1 o'clock. Hmm?